Hello, everyone. Thank you so much for just joining us now. I would like to go ahead and introduce myself for those who did not attend the previous session. My name is Caitlin Bathis-Lasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to our next educational session of the day, which will focus on providing information about lymphoma for newly diagnosed patients. For patients that are newly diagnosed, it can be very confusing to navigate a cancer diagnosis and to prepare and set appropriate expectations for your upcoming clinical journey. It's important for you to understand the resources and support networks that are available through you to help you during your journey. This session will provide a bit of an overview of important information for lymphoma and CLL patients regarding their diagnosis and clinical course, discussing some of the different phases the patient may go through following a diagnosis, such as watch and wait, treatment, relapse, refractory care, and even follow-up care and management. Further information on resources and support will be provided throughout this presentation. Before I go ahead and introduce our speaker for today, there are just a couple of items to note. This session is being recorded, and the recording will become available following the conference. You will receive an email at the time that the recording does become available. At the end of this presentation, we will leave about 5-10 minutes for a question and answer period. Like I had mentioned previously, to ask your questions, you can type them into the questions box, which is located in the middle of the black toolbar at the bottom of your screen. And we will try to get to as many questions as possible within the time we have. So though Dr. Reiman actually did provide a brief introduction at the welcome address, if you were able to attend, it is my pleasure now to introduce him as the presenter for this session. Dr. Tony Reiman is a practicing medical oncologist at the St. John Regional Hospital in New Brunswick and is the Assistant Dean of Research at Dalhousie Medicine in New Brunswick. Dr. Reiman's primary interest lies in patients and research to improve their overall care. This includes banking of biological specimens and clinical data for research, clinical trials of new therapeutic approaches, and multidisciplinary supportive care research in areas such as body composition and exercise. He works primarily with lymphoma patients, multiple myeloma patients, and lung cancer patients. Thank you very much for joining us today, Dr. Reiman. I would now like to go ahead and turn over the presentation to you. Thank you, and you can take it away.
Thank you, Caitlin. It's a pleasure to be here, as I said earlier in my opening remarks. And I'd just like to thank the speakers we've had so far. Ray Hubble gave a great talk about his experience with lymphoma. And I think many of you might learn more from his talk than anything I'm going to say. Also thanks to Dr. Hosseini for giving us a timely update on what's happening with COVID and how it's relevant to people with lymphoma and CLL. So I'm going to dive right in here and give this introductory talk about lymphoma. Many of you listening may be familiar with a lot of this information, but there will be others who are new to understanding lymphoma, and I think hopefully for you that this will be particularly helpful. We're going to try and cover what is lymphoma, how does lymphoma come to the attention of a person affected or to the healthcare team, how is lymphoma diagnosed, what tests do lymphoma patients undergo, and how do we treat lymphoma, and what is the outlook after lymphoma diagnosis. And by the way, this all applies also to people with CLL, and I'll comment just a little bit about that in the talk, but certainly a member of the same group of conditions, lymphoma and CLL. So to explain what lymphoma is, I'm just going to start by just briefly touching on what a cell is. This is, I guess, what you could regard as the smallest unit of life. Our bodies are composed of trillions of cells that develop from a single cell. And these are so small that you could fit 10,000 of them on the head of a pin. And it's amazing that a single cell, a fertilized egg, can turn into all the different parts of our body, and these different parts, different organs contain different kinds of cells. So incredible biology that just goes into creating the human body. So understanding what a cell is a little bit, then we can talk about what cancer is. And then we can talk about lymphoma and CLL as types of cancer. So in any kind of cancer, you have a normal cell in the body that somehow gets damaged, and it's the genetic material of the cell, the DNA, that seems to be most important here, that gets damaged. And this is what we refer to as a mutation. And sometimes these DNA mutations can give a cell the properties of cancer. And one of those properties is that cell will reproduce itself. It will divide into 2 cells, and then those 2 cells will divide into 4, et cetera, et cetera. And in this way, you get cancer growth. So there's basically 2 things that define a cancer. You know, one is that you get a growth. Now, not all growths or tumors, which are words sometimes used interchangeably, or masses, another word for basically the same thing. Not all tumors are cancer. Some tumors are what we call benign. So there are growth that maybe shouldn't be there, but that growth isn't going to behave like a cancer. It's not going to behave in such a difficult way. So tumors that are made of cancer cells, we call them malignant or cancer, cancerous tumors. And what separates a benign from a malignant tumor, because both have cells that have reproduced and multiplied to grow into these tumors, is that cancer cells also have the ability to spread through the body, where benign tumors, they tend to stay put, stay where they are. The cells don't invade into surrounding structures. Maybe the tumor grows and it becomes a nuisance, but the cancer cells aren't there, so there's no invasion or spread of the cancer cells outside of that benign tumor. In the case of the cancer cells can get out of the initial tumor. Often what happens is a few of them will get into the bloodstream, and then these cells can float off through the bloodstream and come to seed in some other organ where new tumors can grow. And on the scan on the right-hand side of the panel here is just an example where this is a PET CT scan where the orange things lighting up are lymphoma tumors, just showing that, this has spread through the body and it's not just in one area. So these are really the 2 main hallmarks of cancer, is the ability to grow into tumors and the ability of these cancer cells to go to seed in other parts of the body and grow into separate tumors elsewhere. People sometimes imagine cancer as one big growth that's all physically connected, but actually it's more like dandelions on the grass, where you might have one growth in one part of the body that goes to seed, and those seeds plant and grow into new tumors in other parts of the body. So lymphoma and CLL can also do this, and that's what makes them types of cancer. So lymphoma then is a specific cancer or a group of cancers, including CLL. These are cancers of a certain type of cell. So I mentioned that the body is composed of many different kinds of cells. So there's a very specialized type of cell called a lymphocyte that when it becomes cancerous can turn into CLL or lymphoma. And so on the left-hand panel, you've got a fairly normal looking lymphocyte there. That's what they're supposed to be like. And then on the right, you see all these funny looking cells that are different from the one on the left. And this is somebody with some type of lymphoma that you can see here. So what are lymphocytes then? Lymphoma is a cancer of lymphocytes. Well, lymphocytes, we all have lymphocytes normally. These are a good thing to have when they're not turning into a cancer. And in health, lymphocytes have a job. They're part of our immune system. And our immune system is, really a whole network throughout our body, as illustrated on the right-hand panel, where you have cells that are part of the immune system residing in different parts of the body, like lymph nodes, which we'll talk about in a minute, the spleen, the bowels. A lot of organs have lymphocytes in them. So their job is to help, really to fight infection or other things that are intruding into our bodies. And infection is sort of the main one. it seems that lymphocytes also have a job in, helping oversee our body to deal with cancer maybe before it can really get out of hand. So lymphocytes can help fight cancer as much as they can become cancer. So lymphoma is a cancer of lymphocytes. Lymphoma can also be regarded in some ways as a cancer of lymph nodes. That's probably really where the name originally came from, because often you find this cancer, lymphoma or CLL, in lymph nodes. And so what are they? Well, here's a cartoon showing on the left a bunch of little round structures. Those are lymph nodes. And you can find them all through the body, and they're connected to one another. They have their own circulation system. Instead of going through blood vessels, these cells can travel from one lymph node to another through what are called lymphatic vessels. It's this whole parallel circulation in our body that allows our immune cells to circulate and to do their job to look for and fight infection. These are often the places where our lymph nodes or where these lymphocytes, can do their work and really gear up their response to an infection. So sometimes when you have an infection, your lymph nodes get enlarged. This is important just because there are reasons other than lymphoma why people's lymph nodes can be enlarged. It's certainly not always due to lymphoma. Sometimes this is a healthy response to an infection. But this is a common place to find lymphoma because, this is a cancer of lymphocytes, and this is where lymphocytes normally like to be. Just stopping for a minute to say, there are leukemias that arise from lymphocytes and not just lymphomas. So what's that about? I guess I'll just say briefly that there are a lot of similarities between leukemias and lymphomas. These can overlap. Not all leukemias are cancers of lymphocytes, but some of them are. Some leukemias are cancers of other kinds of blood cells. But basically, leukemia means that there are many cancer cells in the blood and in the bone marrow. And so, you can have lymphoma cells in the blood and the bone marrow, and you can have leukemia cells in lymph nodes. So there's a lot of overlap there. And in some ways, they're not really all that different, leukemia and lymphoma, especially leukemias that are arising from lymphocytes. So a lot of overlap there. Often it just has to do with how many cells are in the blood or in the bone marrow as to whether we call it leukemia or not. But often the biology of those cancer cells is very similar, and the treatment is often very similar. So how does lymphoma or CLL come to our attention? What are the symptoms? What are the signs? What do you notice? What might your doctor notice or your other healthcare provider? Well, you might see enlarged lymph nodes. And some of the places where you can see or feel those are in the neck, as in the top right panel, in the armpit, as in the left-hand panel, or in the groin, as in the bottom right panel. But there are lymph nodes, as I say, all through the body, and some of these are not easily accessible to see or feel. They're inside, and you can't see or feel them necessarily. So those are the ones sometimes you can see or put your hand on and feel a lump there. So that's a common sign. In addition to the lumps themselves, sometimes people just feel unwell when you have lymphoma. You can have symptoms that might not relate directly to the presence of a tumor in a given location, sort of what we call systemic symptoms or body-wide kind of symptoms. Constitutional symptoms is another word. B symptoms is another word you'll hear used. It's an odd name, but there's a reason for it, which maybe we don't need to get into. But the classic symptoms are fever, drenching night sweats, so soaking the bed sheets at night with sweat, or a significant amount of weight loss, which is often regarded as at least 10% of your body weight in the last 6 months. But there are other constitutional or systemic symptoms. People can have itchy skin. They can just be really tired. There's a number of ways this can manifest. Sometimes people feel kind of like they got the flu. This is just a diagram, of the human body to say, well, you can find lymphoma in just about any part of the body. And so, you can get symptoms related to the presence of lymphoma in virtually any part of the body if it's there. If you have lymphoma in your chest and it's affecting your breathing, you could feel short of breath. If you have lymphoma in your bowel, you could have cramps, you could have changes in your bowel movements, diarrhea, or even constipation. There's lots of different ways this can happen. You could find lymphoma in your skin and see lymphoma in the skin. But any organ of your body virtually could have lymphoma in it. It's not always the case. Not everyone has lymphoma in every part of their body. So everybody's different. So those are some of the ways that lymphoma brings itself to our attention. So how do we then diagnose lymphoma? How do we make that diagnosis? How do we say, okay, this is lymphoma, it's not something else? Well, I guess what I would say is the main way that we start to suspect lymphoma is based on some of those symptoms and signs, first of all. So you go to the doctor or the nurse and they say, oh, gee, you've got some enlarged lymph nodes. We need to think about lymphoma. Or, you've got some of those fevers and drenching sweats and weight loss. It comes to mind. Another very important way that lymphoma comes to mind is, people have scans done to investigate their symptoms, and you can see signs of lymphoma or CLL on a scan, and I'll come back to that in a minute. Other test results like blood tests, can certainly show lymphoma or leukemia cells in the blood, or other signs of the effect of lymphoma on the body. So those types of tests can make lymphoma seem like a possibility. But really, to know for sure that you have lymphoma or CLL, we need to get a sample of these cancer cells, and ideally, a sample of tissue containing these cancer cells, and have that examined in a clinical laboratory, often located in a hospital, but not always, where specialized doctors called pathologists can work with a team of experts in the lab to process and analyze these tissue samples to determine whether they contain lymphoma and what kind of lymphoma. So to obtain this material for diagnosis, well, that's what a biopsy is. So a procedure to remove lymphoma tissue from patient's body so that it can be examined in a clinical laboratory to make the diagnosis. Biopsy is the process of obtaining that tissue, removing it from the body. And there are different ways to do that. And so different patients will have had different experiences with this. But basically, you have to look at where there's evidence that there might be lymphoma. So either, say, in a lymph node that you can see and feel in the neck, or maybe one that's inside the body that you can see on some type of CT scan or other test. So you need to decide, what part of the body you're going to try and obtain this lymphoma tissue from. And you're going to try and obtain as much tissue as you can on the one hand, so that the hospital laboratory folks have plenty to work with. You want the procedure to be easy, both for the doctor obtaining the tissue and also for, of course, the patient, for lots of reasons. One being that the easier it is to get the tissue, the less likely it is that it's going to be damaged as it's collected. And the more damaged it is during the process of getting the biopsy done, the harder it can be to work with the tissue to make the diagnosis. But also, of course, you want it to be as easy for the patient as possible. You also want to try and get this done in a timely manner. And so sometimes for a given patient, and depending on what resources are available and what their particular details of their case are, one type of procedure might be preferred over another for a given patient to obtain a biopsy. The ideal procedure is to actually have a procedure to remove a lymph node, or maybe a piece of a lymph node, or a piece of an affected organ, so that you have a little hunk of tissue that can be examined in the hospital laboratory. And so often that's pretty straightforward. If there's a lump that you can see and feel in your neck or your armpit or your groin, your doctor can also see and feel that. A surgeon can see and feel that, and do a minor surgery, essentially, to remove some of that tissue. That's sort of shown in this cartoon. And often this can be done without a general anesthetic, if the lump is in a location that lends itself to having this done just with local anesthetic. But sometimes you have to have go under general anesthetic to have this done. Otherwise, people sort of put to sleep to have the procedure. But often you don't need to do that. It really just depends on the case and the location and the judgment of the doctor doing the procedure as to what's best for the patient. The second sort of best approach in terms of the amount of tissue you can obtain, if you can't remove a lump easily with surgery, then maybe you can biopsy it by putting a needle into it, a hollow bore needle that you can use to core out a few little pieces of the tumor so that it can be examined in the hospital lab to see if it's lymphoma. So this is an example here of someone who's lying on their belly, having a needle inserted through the skin and into a lump that's inside the pelvis, not accessible to see or feel. And this is done usually in the diagnostic imaging department of a hospital, and samples are collected and sent to the laboratory. And people are typically given some sedation for this, some local anesthetics and freezing at the site of the needle insertion. And this often goes remarkably smoothly. So it's nice because it's probably a little easier in some ways than having a minor surgery to get the biopsy. But the downside really, I guess, is you don't get as much tissue for the lab to work with. And the more tissue you get and the better condition it's in and the more quickly it gets to the lab, the more likely it is that a diagnosis can be made with that biopsy. Sometimes people will have just a very thin needle inserted into a lump like this, and you can just basically withdraw some of the contents of a tumor into a syringe and then spread those out onto a slide as shown on the right-hand panel to look at under the microscope. This can be a great way to obtain some lymphoma cells or leukemia cells, but it's generally not the preferred way to make a lymphoma diagnosis, just because you can't always tell exactly what kind of lymphoma you have just from doing this. Sometimes you really need that hunk of tissue so you can look under the microscope and see what is the architecture of that tumor to make the diagnosis. Just seeing the cell sometimes doesn't tell you. And also sometimes you can't even tell that you've got cancer in that lymph node when you stick a needle into a lump of lymphoma. Some types of lymphoma, the cells actually look pretty normal. And in other cases, the entire lump isn't necessarily made of lymphoma. So if you put the needle in and you don't get any cancer cells out, it might be what we call a false negative result, where there's lymphoma in there, but you just didn't get it with your needle. So this is sometimes done, but it's not usually sufficient. Usually you need at least a needle core biopsy or a surgical biopsy. So, typically within a week or two, you've got a report from the hospital lab. If we're in a hurry, we can usually get them to give us at least an initial idea in a day or so, whether there's lymphoma there and maybe what kind. But usually it takes a week or two to get all the work done, sometimes longer. But usually within a few days, if we really need it, we can get enough information to start heading down the road of deciding what to do next. So beyond making the diagnosis with a biopsy, what other tests are needed? A big part of the testing involves trying to determine how widespread the lymphoma is in the body. And so we use the term stage or staging to describe just that, understanding how widespread a lymphoma is in the body. And we use a shorthand system to describe the staging, where it's a numerical system, typically from stage 1 to 4, stage 1 being lymphoma that's relatively confined to one part of the body, all the way up to stage 4, where the lymphoma is more widespread and is into the organs and not just in the lymph nodes. So we want to determine this because it's going to help us understand what is the outlook and also what is the best treatment. So to determine this, we'll do some scans, take some pictures of your insides to look and see where the lymphoma is. CT scans are very commonly used for this. These scans use X-rays to create images of the body, as shown here. And the experience is often just as you see on the left-hand side, where a table is used to slide you through a sort of donut-shaped opening that is used to take these X-ray pictures and reconstruct these images of your inside. Here's an example of a lymphoma from that patient who's having the biopsy. These images are from some of my patients. Here's an example of a PET scan. This is actually a PET scan image fused to a CT scan image. And often the machine can do both at once. And the experience of having this type of scan is very similar to having a CT scan. In both cases, you get injected with some material intravenously and you slide through this opening and the pictures of your insides are taken. And the injections are used to highlight what we're seeing. In the case of PET scans, you're injected with a radioactive form of sugar, the idea being that lymphomas are very hungry and take up sugar at a high rate. And so we can image the radioactivity that accumulates in the lymphoma when you're injected with this radioactive sugar. The amount of radiation exposure having a scan like this is still pretty low. And there's also some radiation exposure along with the CT scan. But again, it's relatively low and certainly well worth undertaking for the information it provides. We sometimes use MRI scans, which are a different form of imaging the inside of the body using magnets to create the image. And this is often done to look at the brain or the spine, the spinal cord. Those are parts of the body that are probably best imaged with MRI scans. These can be a little bit harder sometimes because the hole that you slide through to get the scans done is smaller. You have to spend more time in there. It's kind of loud sometimes. So people sometimes find that more difficult, especially if you don't like enclosed spaces. But usually we can get around that and get people through it. And it's very important to do for lymphoma in the brain, lymphoma in the spine. Sometimes lymphoma can hide in the bone marrow, and sometimes the scans don't show that. And so we need to do a bone marrow biopsy if we want to know if there's lymphoma inside the bones in the bone marrow. That's just another place that lymphoma likes to be. We can often see signs of lymphoma in the bone marrow on PET scans now, and so we don't always have to do bone marrow biopsies where we used to do them in virtually all cases of lymphoma, but sometimes we still need to do this. So basically, it's typically done in the clinic, someone lying on their side, perhaps, with a needle inserted into a bone in the back of the pelvis. And then some marrow can be obtained through a needle. Sometimes we have to also do some tests to evaluate a person's ability to withstand some of the treatments that we might recommend to them, which can potentially affect various organs in the body like the heart, lungs, liver, kidneys, blood, etc. And so we often do a pretty thorough evaluation of how well a person's organs are functioning before we choose the treatment. So these are just some of the potential tests that could be done. Ultrasounds or scans of the heart. Pulmonary function tests or breathing tests where you breathe into a machine to measure your lung capacity, and lots of blood tests. So once all the evaluation is done, the diagnosis is made, understand the stage, the type of lymphoma, and the patient's general health, we then consider recommending treatment. So you can think of cancer treatment as generally being of a limited number of types of treatment. And you can think of it kind of this way. Some treatments are aimed at treating a tumor in a particular part of the body. And so perhaps you can have that removed with surgery, or perhaps you can have it treated with high energy X-ray treatment with radiation therapy. Sometimes if a lymphoma, is throughout the body, which is common, we often have to give people some type of treatment that can also circulate through the body to hit these lymphoma cells wherever they might be. And so we call that systemic therapy, or therapy that goes throughout the body. And that's often in the form of drug treatment that could be administered either intravenously or perhaps by pill or some other form of medication, or cell therapies, which we'll talk briefly about and which you'll probably learn more about in some of the other sessions over the course of the next couple of days. So we'll get into a little more about those treatments in a second. I just want to highlight here that for some people with lymphoma or CLL, you really don't necessarily benefit or need or should be treated right away. Sometimes it's better not to take treatment right away. So there are certain kinds of lymphoma and certain presentations of chronic leukemia that people can potentially live with quite well for many years without any treatment. And so it's wise to see what happens, because treating right away sometimes doesn't improve the outcome. Sometimes things will go better initially without treatment. This is particularly true in cases where we expect the lymphoma to progress very slowly, and where a treatment has not yet been invented that we think could easily get rid of the lymphoma completely. So in those cases, we save the treatment for when it's more needed, because the lymphoma or leukemia is causing the patient, difficulty, or is anticipated to soon do that. In that case, treating a patient who's not initially required therapy, maybe waited 3-4 years before they needed treatment, can really benefit from treatment. Treatment can be very effective in dealing with these types of lymphoma or leukemia that didn't initially cause problems, but have then gone on to start causing problems, and put the lymphoma into a type of remission that hopefully can last for a long time. So sometimes we don't treat right away, and that's a hard one to get your head around when you come to the cancer clinic and you're thinking, okay, I've got cancer, I got to do something about it. And for most cancers, that's how we approach it. But there are some types of lymphoma and leukemia, and some other kinds of cancer where this is a better approach. So just going through the different types of cancer treatment and how they apply to lymphoma, very briefly, I'll just say that surgery is very important for lymphoma diagnosis. We talked about earlier, getting a biopsy. It's often done through surgery, but it's rarely used as lymphoma treatment. Now, some of you as lymphoma patients may have had surgery to treat lymphoma, and certainly it's very appropriate in some instances. But most of the time, it's not really that helpful to try and have surgery to remove lymphoma. We'll get into why that is as we go along. So, not usually part of the treatment. More integral part of the diagnosis procedure. So the preferred local therapy for lymphoma is radiation therapy, as I mentioned earlier, shining radiation on a tumor with a machine as depicted here. Having radiation treatment, in the mechanics of it, or something like having an X-ray taken, but the radiation is of higher energy, so instead of X-rays, it's gamma rays, and the treatment is often given once a day for perhaps a few weeks to expose the lymphoma over time to a dose of radiation that might eradicate it, at least from a given location. Lymphoma is quite sensitive to radiation, so if we radiate a lymphoma lump, more often than not, it melts away. And we can usually use a lower dose of radiation to treat lymphoma than we have to use to treat other kinds of cancer, because it's so sensitive to radiation most of the time. This isn't always the case, but it often is. And so that means that we can often get away with fewer side effects from radiation to treat lymphoma than we see treating some other kinds of cancer. So this is a form of radiation called external beam radiation therapy, where we shine the X-rays from the outside of the patient at the lymphoma. There are other ways of delivering radiation therapy, which maybe we won't get into in the interest of time, which have been tried over the years for lymphoma, which are still occasionally used. So typically radiation is used either to try to cure a lymphoma that is apparently localized to one location. That's not a common scenario, but it happens from time to time. More commonly, we're using it to treat a tumor that's causing particular problems. It's in a bad location, or it's causing a lot of discomfort or something like that, and it really needs to be dealt with urgently. More commonly, we treat lymphoma with systemic therapy, as we'll talk about shortly. And if there's residual lymphoma present in a limited number of areas, after we give, for example, chemotherapy or some other kind of drug treatment, we might come back at the end and say, okay, there's some lymphoma still in this one area. Let's treat that area with radiation to try and get rid of the last bit of lymphoma that might be there. I would say most lymphoma patients need to have some form of systemic therapy, and initially we're usually talking about drug therapy. And this is the idea of people coming in. Typically they get injectable treatment, often given intravenously, sometimes in combination with pills. Some lymphoma treatments or leukemia treatments are just given in pill form. So there's different ways to administer lymphoma drug treatment. But the idea is that lymphoma is a systemic disease, and that's why we often have to give systemic therapy. So, if you only have a lump on your neck and you get a PET scan and all kinds of scans, and we don't find lymphoma anywhere else, you might have a bone marrow biopsy, we don't even see it in your bone marrow. The thing is, there might still be lymphoma elsewhere in your body. It might not just be in that one location. So for that reason, if we just treat the one area with surgery or radiation, often the lymphoma recurs elsewhere in the body at a later time because there was already lymphoma there and there wasn't enough of it to be initially detected. So usually, more often than not, we need some type of drug treatment to treat lymphoma. Certainly leukemias are also systemic illnesses or conditions that require drug therapy or systemic therapy frequently. Also, these local therapies like radiation surgery, you can only do so much of that. You can't remove lymphomas that are all over the body. You can't really safely radiate the entire body easily, although it has been done. But generally, it's better to use it as localized kind of therapy to a limited part of the body. And so that's usually not sufficient to deal with a systemic condition like lymphoma or leukemia. So that's why we got to use systemic therapy. And so we're talking about drug therapy or cell therapies. And I've listed them here briefly, but I'm just going to keep going because I've got a slide on each of these for you. So chemotherapy is the traditional cancer drug treatment. And this is the stuff you think of that can cause hair loss, nausea, that can suppress your immune system and make you susceptible to infection. And of course, we use chemotherapy to treat many different kinds of cancer. And it's still an important part of the treatment of lymphomas and leukemias. But not every patient needs this type of drug treatment. Sometimes we can use something else, and we'll get into the other kinds of drugs that we have. Often, drugs are used in combination. This way you can try and treat the lymphoma with different drugs that work in different ways and can work better together than they might individually. And so there's many different drugs, combinations, and schedules that we'll use. So there isn't any one kind of what to expect for your drug treatment, that I could give you on a single slide, because the treatments are different for different patients. Steroids are a form of lymphoma or leukemia treatment, and these are drugs like prednisone, dexamethasone. These are cortisone type steroids. They're not the sort of bodybuilder type steroids. And these are often used for many reasons, not just to treat lymphoma, but they're used for many things in medicine and in cancer care. But lymphomas can shrink just by giving people some steroid medicine. And so they're often part of the treatment. Often they're combined with chemotherapy. These steroid medicines have their own side effects. And so we try not to give them to people every day, because the higher is the daily dose and the more of your time you spend on these steroids, the more of these side effects you can get. So usually we try to give these for limited periods of time to limit the side effects. But they are an important part of treatment for many types of lymphoma. We have newer drugs that have not yet sort of eliminated the need for chemotherapy, but maybe one day we'll be able to get rid of chemotherapy as we develop newer medicines that maybe work better and maybe are better tolerated than chemotherapy. For now, we typically combine some of these newer sort of designer drugs that we have for lymphoma. Often these drugs are combined with chemotherapy. Sometimes we can give these newer drugs on their own, and that's often really a good thing. So one type of drug is monoclonal antibody drugs. So suffice it to say that these drugs are inspired by and even created using the immune system to say, okay, well, if the immune system, can attack invaders and potentially help deal with cancer on its own, can we harness that and create drugs that are inspired by the immune system to treat lymphoma? And so we have drugs like that. I mean, rituximab is a monoclonal antibody type drug. And these are basically protein drugs that are created, and what they do is they bind to other proteins or targets that are on the surface of lymphoma cells. And maybe these targets aren't found on a lot of other normal cells, healthy cells in the body. So a form of targeted therapy that's going to hit the cancer cells relatively selectively. I mean, these drugs still have potential side effects and don't only hit the cancer cells, but they have generally fewer effects on healthy cells than chemotherapy, these monoclonal antibody drugs. We have other types of targeted therapies that are not monoclonal antibody drugs or immune system inspired drugs, but they're chemical drugs that have been designed to hit a particular target within a cancer cell. Ibrutinib or zanubrutinib or acalabrutinib, these drugs are used to inhibit a protein called BTK that's driving some types of lymphoma and leukemia is an example. So some of you may have been on these types of drugs. These are small molecules, so they can often be taken as a pill, get absorbed into your system, get inside cancer cells, and hit these targets within the cancer cell to halt their growth and maybe to kill them, to put the cancer into some kind of remission. So these drugs can have side effects too. Sometimes, again, they don't only just target the cancer cells, but we tried, these drugs are designed to try to target the cancer cells as specifically as possible to try to minimize the side effects. All these drugs still come with potential side effects that you need to learn about as you go through your treatment. So that's briefly touching on drug therapy. Cell therapies are another form of systemic therapy. And cell therapies are very specialized forms of cancer treatment that are offered at a more limited number of cell therapy centers across the country. Not every cancer center does cell therapy. If you thought fancy new cancer drugs were expensive and resource intensive, well, cell therapies are very expensive and resource intensive, but very important parts of lymphoma and leukemia treatment. And there's stem cell transplant as a form of cell therapy, and then there's CAR T therapy and other types of sort of newer cell therapies that are in development. CAR T being the main one that's now on the being used as a matter of standard treatment for certain situations with lymphoma and leukemia. So we'll start with stem cell transplant. I mean, briefly, the point of this is that blood stem cells are specialized cells in the bloodstream that can reconstitute a person's blood and immune systems. And so stem cell therapy is administering blood stem cells intravenously to a patient. Sometimes these are the patient's own stem cells that have been harvested ahead of time. And sometimes these are stem cells that are provided by a donor. And autologous is the type of transplant where the patient is his or her own donor, and allogeneic is the type of transplant where someone else is the donor. So what's the point of giving yourself a dose of your own stem cells? Really, this is a convoluted way of trying to get a person through a high dose of chemotherapy. So the maneuver that's going to treat the lymphoma here is high dose chemotherapy, which aims to wipe out the cancer. The problem with high dose chemotherapy is that it might wipe out your blood and your bone marrow. There's a good chance it's going to do that. So the solution is we can collect these blood stem cells from the patient before we give them high dose chemotherapy, put them in the freezer, and then we can thaw them out after the patient's had high dose chemotherapy and give the cells back to the patient. So this is a way of getting around this very difficult side effect of high dose chemotherapy, to allow a patient to receive high dose chemotherapy and get through it and have a blood and bone marrow that's intact at the end of the day. So we use this most commonly to treat relapsed types of lymphoma that are still sensitive to chemotherapy, but need a higher dose of chemotherapy to try to eradicate them. So this is, given typically with curative intent, or at least to provide a long-lasting remission to a lymphoma patient. A blood stem cell transplant from a different person, from a donor, on the other hand, is kind of a different thing. We used to think it was the same thing, but we learned that actually part of the reason that it's therapeutic to do a stem cell transplant with somebody else as the donor is that you're essentially transplanting the donor's immune system into the patient, and the donor's immune system can fight the lymphoma or leukemia. So this is remarkable and a powerful treatment. Powerful in two ways. In one way, it can sometimes eradicate a lymphoma that's otherwise resistant to treatment. It's also powerful in that it's a bit risky because this is tough treatment, and people can develop side effects from the donor's immune system, causing disease in the patient called graft versus host disease, or infection that can arise from the immunosuppressed state that patients are in for a significant length of time when they go through this. So it's a little risky to have this type of treatment, and we don't do it for everybody. The other type of cell therapy that you'll hear a lot about as you go through this is CAR T therapy. Basically, this is a method of genetically engineering a patient's own immune cells to attack his or her cancer cells. And this is particularly effective or successful so far for certain types of lymphomas and leukemia, particularly B-cell lymphomas and leukemias. So we actually use a patient's T cells, which are another type of lymphocyte. In someone with a B-cell lymphoma, their T cells are still healthy T cells, and we can collect some of those from the patient. They can be genetically engineered so that they will attack the lymphoma cells. They can be given back to the patient and can potentially cure the lymphoma or leukemia. So this also carries some risks with it, but this is something that's only been available for a relatively short time for patients in Canada, and there are a lot of places in the world where this is just not available. It's really the developed world that's trying to figure out how to deliver this, and we still haven't made it, as widely available as it probably needs to be because it's so resource intensive and challenging. But progress is being made rapidly with this, and so some of you may have received this treatment. I'm nearing the end of my time with this particular talk. I'm going to give another talk in a few minutes here, but we'll still have time for questions because my second talk is short, Caitlin. So people have a lot of questions. What is the outlook after a lymphoma diagnosis? Will my lymphoma go into remission? Is it going to relapse again in the future? How long am I going to live after this diagnosis? How's my life going to be? What are going to be the long-term effects of the lymphoma or leukemia or the treatment on my life? Am I going to be able to get back to normal activities like work? How am I going to be monitored after my treatment? And I'm not going to answer those questions. I'm just going to say it varies. And there's not one answer that applies to every patient. And there's no way to predict with certainty what an individual patient is going to experience either, and how things are going to go. But you can still get helpful answers, but you're going to probably need to get those from your lymphoma healthcare team, and those answers will be informed by details about your individual case, as well as the research that's out there and the experience of your team and their colleagues that they can consult for advice if they need it. So I'm going to stop there, and I know we're just about at the top of the hour, but I still think we could take some time for questions before we do the second talk, because as I say, that'll be a little shorter.
Wonderful. Thank you so much, Dr. Reiman, for your excellent presentation. Thank you for thoroughly addressing the clinical course for a lymphoma patient, including everything that they would sort of need to know from diagnosis in order to help prepare for their upcoming journey. Some of the comments we received back already was wishing they had this as soon as they were, diagnosed or referred for a diagnosis. So this presentation had a lot of very valuable information. We do have some time for a couple questions, and we have some questions coming through, which is great. So I'll go ahead and get started with those. So are the B symptoms that you mentioned present in all lymphomas? If the B symptoms are, very mild or very bad, does it mean possibly that, my lymphoma might be progressing, or is that a later stage at the time of diagnosis?
Right. So I guess the big thing that these B symptoms, fever, night sweats, weight loss, help us with is if you think that maybe the lymphoma is just localized to one part of the body, but a person is having a lot of these symptoms, we often think it's probably a sign that there's more lymphoma in there than meets the eye. So we tend to think we maybe need to treat that patient as though they've got more widespread lymphoma than it first appears. But usually these are symptoms that the lymphoma is somehow active. And often it's a sign that the lymphoma needs to be treated, even if it's one of those types of lymphoma that doesn't always need immediate treatment. This is sometimes one of the reasons we think, okay, maybe this person should be treated now.
Okay, great. Thank you so much for clarifying that. You also mentioned, obviously, with the list of treatments that you provided, that there are possible treatment-related side effects that might occur. And so for those patients that may not have started treatment yet, knowing and again, preparing for what to expect, are there ways that some of these side effects may be managed? Can they last long? What should patients really try to discuss with their doctor prior to starting treatment?
Well, it is information overload at the beginning, and there's a lot to learn, and you don't necessarily get your head around it all right away. And your healthcare team will try and provide this information to you. And as Ray described, sometimes it can be very daunting to hear about this for the first time, what treatment's going to be like. You can get a very negative view of it because your healthcare team feels compelled to advise you of everything that can possibly go wrong. And I guess that's important, and it's to a certain extent there's no getting around it, but it can be a difficult experience to hear about what could go wrong. The reality is you're not going to get all the side effects that you hear about, and sometimes in spite of hearing about all kinds of potential side effects, the treatment actually goes fairly smoothly, and there's always side effects, but sometimes they're quite manageable and you can get through it. Other times it's very difficult, and so it does vary. But in terms of how you can prepare for that, I think you'll be given some written information, you'll be given some verbal information. There will be educational tools that your cancer center hopefully will provide to you that helps you learn about what to expect, what to watch for, who to call. And people are going to be different about this. Some people will rather just say, look, I'm just going to call if I'm having a problem, and I'm not going to try and become a doctor and learn all this stuff. Other people will say, wow, I think knowledge is power, and I want to learn all this stuff as much as I can and be prepared so that I know what to watch for and what to do. And so people approach it differently, and I don't think there's a one right or wrong way to do it. But I do think, the more you can learn about this stuff, probably the better you're prepared you're going to be. You'll be an expert on it just about the time you finish your treatment. The ironic thing.
Great. So we have, I think, time just for one last question. You mentioned sort of a number of different diagnostic tests. Might patients need all of these tests? Might they need multiple biopsies or other molecular tests? And why would they need more tests?
So, the essentials are to have the scans to see how widespread the lymphoma is in your body, and to get a biopsy that tells us that you have lymphoma, and B, what kind of lymphoma it is, we're going to get into in a minute. That same biopsy is typically what is used to do the additional molecular testing, to understand exactly what kind of lymphoma you have, what characteristics it has, to inform the treatment decisions, and to inform the discussions about what is the outlook. So you don't necessarily have to have additional tests to get that information, but you do sometimes have to have a biopsy repeated if the first one just didn't provide a sufficient amount of good quality tissue to get all the work done and make the diagnosis.